Welcome to our mini molecular tumor board on ovarian cancer. My name is Sonia Alexander, and I am joined by Ilian Cortez. To set the stage for today's discussion, I'd like to begin with our patient case. This will help ground the data we'll review in a real-world clinical context and highlight the role of comprehensive genomic profiling in guiding ovarian cancer care. The patient is a 58-year-old female who initially presented with early satiety and abdominal bloating. Imaging raised concern for ovarian cancer, and after surgical intervention, she was unfortunately diagnosed with stage 3C high-grade serous ovarian carcinoma. She was started on standard of care chemotherapy and referred to genetic counseling. Germline testing came back negative. To further inform her treatment options, a Foundation 1 CDX test was ordered on her surgical tissue specimen. This slide gives an overview of the histologic subtypes of ovarian cancer and the genomic alterations most often seen with each group. About 90% of ovarian cancers are epithelial carcinomas, which include several important subtypes. The most common is serous carcinoma, making up just over half of all cases. High-grade serous cancers most often always have TP53 mutations and often show homologous recombination repair deficiencies, including BRCA1 and BRCA2. Beyond epithelial tumors, there are rare groups which carry distinct genetic signatures. So overall, the genetic landscape of ovarian cancer is diverse, and recognize these subtype-specific patterns is important for both testing approaches and in identifying potentials for targeted therapy. In the recurrent setting for ovarian cancer, professional guidelines emphasize a broad range of molecular testing to help guide treatment decisions. BRCA1 and BRCA2 remain central, both for hereditary risk assessment and because of their strong therapeutic implications with PARP inhibitors. Closely tied to this is testing for homologous recombination deficiency, or HRD status, which further refines treatment strategies. Other recommended tests include HER2 and folate alpha receptor, or FOLR1, by immunohistochemistry, both of which can identify patients eligible for targeted antibody-based therapies. It's also important to evaluate microsatellite instability and mismatch repair deficiency, as well as tumor mutational burden, since these can point to benefit from immunotherapy. Together, these guideline-based recommendations highlight how comprehensive testing is moving well beyond BRCA alone, expanding opportunities for personalized treatment in ovarian cancer. Back to our patient. With newly diagnosed ovarian cancer, molecular testing revealed a BRCA1 loss involving exons 4 through 23. This alteration mediates homologous recombination deficiency, which is confirmed by the positive HRD-Sig result. The microsatellite status was stable, and the tumor mutational burden was low at 4 mutations per megabase, suggesting immunotherapy is less likely to be beneficial here. Other alterations include CDKN2A loss and a TP53 splice site mutation, though neither currently has approved targeted therapies in ovarian cancer. Clinically, the most significant finding is the BRCA1-driven HRD, which supports the use of PARP inhibitors. And I'll turn it over to Ilian.
Thank you, Sonia. My name is Ilian Cortez, and next I'll review the 4 common types of genomic alterations. Mainly, they can be subgrouped into mutations and large alterations. Mutations include point mutations. These are substitutions of a single base pair. Insertions and deletions, also called indels, can include additions or loss of 1 to 50 base pairs, which can cause frameshift mutations. Large alterations include copy number variations. These are changes in gene copy number, such as amplification or deletions, also referred to as copy number loss. At FMI, we report only homozygous copy number losses, meaning loss of both copies of a gene or at least one exon. And finally, we have rearrangements. These are large-scale changes like inversions or translocations that can disrupt gene function or regulation. Importantly, different genes can show distinct alteration patterns. In ovarian cancer specifically, we can detect different types of genomic alterations in genes involved in homologous recombination repair. The figure on the right shows the prevalence of these alterations in ovarian cancer with the stacked bars color coded by alteration type. In this real world study, across most genes, substitutions and indels were the most frequent alterations. Homozygous losses, shown by the red bar, were rare and seen only in 1.6% of specimens. BRCA1 and 2 were the most commonly affected by these homozygous losses. This table summarizes FDA approved PARP inhibitors for ovarian cancer. Therapies include niraparib, olaparib combined with bevacizumab, and rucaparib. These therapies are used in first line or recurrent maintenance settings with efficacy linked to biomarkers like BRCA mutations, can be germline or somatic, as well as genomic instability as measured by different assays. Key supporting trials are listed on the right-hand side. Although not a biomarker included for PARP inhibitor eligibility, homozygous loss of genes involved in homologous recombination repair have been linked to prolonged survival on PARP inhibitor monotherapy in ovarian cancer using a real world study. The Kaplan Meier curves show real world survival outcomes after PARP inhibitor initiation by homologous recombination repair status. Compared to those with other types of homologous recombination repair alterations or no alterations, patients with homologous recombination repair homozygous loss had the longest PFS and overall survival at 25.4 and 59.4 months, respectively. Prolonged real world survival here mirrors data already described in prostate cancer. So, why would copy number losses of homologous recombination repair genes lead to a longer survival compared to mutations? So, in the setting of BRCA mutations, reversion mutations that lead to restored BRCA function have been linked to resistance to PARP inhibitors. In this patient case example on the right, 4 reversion mutations were identified in a liquid biopsy in addition to the primary somatic mutation in BRCA. BRCA copy number losses are associated with longer benefit on PARP inhibitor, likely due to the inability to evolve reversion alterations. And next, we'll review Foundation Medicine's homologous recombination deficiency signature or HRD signature. Mechanisms underlying HRD include upstream inactivation of BRCA or other genes involved in homologous recombination repair. Tumors with HRD show characteristic DNA changes referred to as genomic scars. These scars include various large scale genomic copy number changes. Foundation Medicine's HRD signature is a pan cancer biomarker that uses more than 100 copy number features to capture the nuanced HRD phenotype, representing an improvement over GLOH or genomic loss of heterozygosity, which was a biomarker for HRD previously available only for ovarian cancer and related subtypes. And I'll turn it over back to Sonia.
Thanks, Ilion. Great job with the data. This slide shows real-world outcomes with PARP inhibitor maintenance in ovarian cancer from the Flatiron Foundation Medicine database. Looking at the top half, patients who were HRD-Sig positive consistently benefited from PARP maintenance, regardless of whether they had BRCA alterations or other HRR alterations or no HRR alterations. All hazard ratios are well below 1, showing longer progression-free survival. In contrast, patients who were HRD-Sig negative, shown at the bottom, did not see the same benefit. Demonstrating within BRCA subgroups, HRD-Sig positivity identifies patients who gain meaningful benefit from PARP maintenance, making HRD-Sig a valuable biomarker beyond BRCA status alone. The key takeaways being guidelines support broad panel testing for patients with advanced ovarian cancer, because beyond germline testing, somatic alterations, especially in BRCA and other homologous recombination repair genes, can identify patients who benefit from PARP inhibitor therapy. Foundation Medicine's HRD signature biomarker, or HRD-Sig, provides additional insight by capturing diverse mechanisms of homologous recombination deficiency. And importantly, in the patient case study, the patient's somatic BRCA loss was clinically meaningful. It made her eligible for PARP therapy despite her germline testing being negative. Thank you so much for joining us today. I hope you learned something.